Okay, so as we were discussing before we were rudely interrupted by the end of part one, we had just asked the patient to move the limb by themselves through the full range of motion. So they completed that shoulder abduction for us. And a key point to make here is that we now have established that they have a 3 out of 5 strength at least. They can move the limb through the full range of motion against gravity. So once a patient has done that, we will then apply resistance, and if they are able to tolerate moderate resistance, it's a 4 out of 5, maximal resistance, a 5 out of 5. And we'll discuss this further when we're in class. But just discussing the sequence here. Let's see, how do I go to the next slide here? Okay, so looking at the sequence, we have completed number 5. Then we place the limb at mid-range. Remember the force length curve we discussed previously. That's where they should be able to generate the maximum amount of force. And then we provide manually a resistance perpendicular to the ground and have the patient resist us. We decide if it was moderate or strong resistance, and we can then assign a grade of 4 or 5 or something in between there. We'll discuss that in lab. Now, if the patient is unable to move the limb against gravity through the full range of motion, we know that they are going to be given a grade of less than 3 based on our graph here, our table here. And so therefore, to get a 2 out of 5, they can move the limb through full range of motion with gravity eliminated. To get a 1 out of 5, they're unable to move the limb, but we can visibly see or palpate a flicker or some sort of muscle contraction. Now, we will talk about sorry, wrong direction. We'll talk about in lab how to determine an anti-gravity position, but for now we're just discussing the sequence for manual muscle testing. So clinical decision making for manual muscle testing, and we'll discuss this in class, so I won't spend a lot of time here, but in essence, looking at all of these steps and asking yourselves, why is this the sequence for manual muscle tests? So why do we need to explain the purpose to the patient? Obviously, so they understand what we're doing and why. Gravity resistance, we want to start there because we want to determine, are they 3 out of 5 or above, or less than that? And that then allows us to either apply resistance if they can move the limb through the full range of motion against gravity, or if they are unable, then we need to place the patient in a gravity eliminated position. And so that's kind of why we start where we start. And let's see, of course we want to, we already talked about number 3. The reason for moving the limb through the range of motion is to make sure that there is no impingement or other obstruction that would prevent them from moving it through the full range of motion. We don't want to be fooled and ask the patient to do the movement, and when they can't, make the assumption that it's weakness because it could be a joint issue or something else that's happening. And then returning it to the starting position because we want them to be able to then show us that they can move the limb against gravity through the full range of motion. Now we ask the patient to perform the movement while we're palpating the muscle, and that gives us a lot of good information about is there any joint pain or joint sound or crepitus that's happening with the movement. And then we apply the resistance. That's how we're able to then assign a muscle grade to them. And if we need to put them in gravity eliminated, that's how we know it's going to be less than 3 out of 5, and then we assign the grade. Okay, so patient positioning. One of the key points that needs to be made about manual muscle testing is, and it relates to our practice in lab. All of you are healthy and able-bodied subjects, and so when you're practicing with your lab partner, he or she is going to likely have a 5 out of 5 strength on all muscles. Clinically, when we are conducting a manual muscle test, it will be because our patient is having some sort of an issue, and so we are We will get a 5 out of 5 at times when we're testing patients, but very often we're not even going to use our time clinically to conduct a manual muscle test unless we are uh, quite certain that there is a deficit there. So that being said, when a patient does have weakness in a muscle and you're asking them to move the limb through the range of motion, you're asking them to uh, not let me move you. Yeah, as we said, that would be the terminology. We're providing resistance. They are going to do their best. And if a muscle has weakness, often they will compensate by using other muscles to perform what we're trying to have them perform. And so that is one of the big reasons for the standardized patient positioning that you're going to learn and memorize. So that we are sure that we're testing the correct muscle and we are sure that the patient is not quote unquote cheating. Our patients typically don't try to cheat. They are coming to us so we can help them. But as I said, we're asking them to, okay, push as hard as you can. I'm going to give you resistance. They're going to try the best that they can, and they may use other muscles that aren't weak. So that's why patient positioning is so important. Um, so we'll talk about in lab some of the ways, the reasons for the positioning, and we can provide stability to different parts of the body manually or by positioning the patient a specific way. One example of that, all the rotator cuff muscles of the shoulder uh, originate on the scapula. And so when you place a patient in a supine position, now their body weight is resting on their scapula, and so that's an example of positional stabilization. Um, Also, when a patient is in a seated position on the edge of a treatment table, their pelvis, based on their body weight, has some degree of stabilization. So a lot of times we will utilize patient positions to enhance that stability. And also patient positioning, if we're trying to allow the patient the freedom to conduct a movement, we want to allow that segment that we're testing to be able to move freely. Um, and so as we talked about patient positioning, we want the joint to be positioned at the beginning of the range of motion. Why? Because we want to be able to verify that the patient can move that joint through the full range of motion, either against gravity or with gravity eliminated. That's part of the assignment of the muscle grade, is their ability to move through the full or a partial range of motion. So that's another element of patient positioning that relates to assigning the correct grade. Uh, Finally, patients must be able to safely assume the position. And there are many cases where a patient is not able to tolerate a supine or a prone position. And so when it is necessary to uh, deviate from the typical standardized position, we can do that. We just need to document that. Again, the whole purpose of manual muscle testing is to compare a patient against him or herself over time. And it's a great way for us to be able to document evidence of the efficacy of our treatments that we're implementing, because now we can show that over this 2-week or 6-week period, for example, a patient has increased in their strength. And so that helps the referring physician see that our services are making a positive difference. It also helps third-party payers, such as insurance companies, to see that our treatment is justified and reimburse for those services. So the whole purpose of documenting, well, first of all, the whole purpose of following these standardized procedures is to ensure that we are comparing apples to apples. We're comparing shoulder strength of this patient on August 1st to shoulder strength of the patient on August 15th, and everything else should be standardized and the same. And the only variable should be the strength of, for example, that shoulder abduction movement. So when we need to modify the position, it's now maybe not a perfect manual muscle test because the patient's in sitting and they should have been in supine, for example, but we document that, and we then can still use the same procedure in the future to compare our findings. So we will see you in lab to practice and discuss further all of these concepts.